It's great to see everyone here in Adelaide, and we should mention that this is also the city where Lawrence and William Bragg started their career and studied at the University of Adelaide. So, we have quite a long history in this town. So, I guess I'll start off. Thank you everyone for being here. Thank you to the panel for joining us. I was asked to give a few words and set a bit of a scene about the issues we have in Australia. I kind of failed in that direction, and these are meant to be issues that we want to raise awareness about. So we'll see if we're raising important issues or if we know the issues already. And I guess for me, coming from a mining background or an industrial background into medicine, I always reflect on the differences that I saw between mining or an industrial background and medicine. And really the WHS approach is quite different. There's very much a safety focus in industry that is turned around a little bit in medicine. And I guess the other difference is that within an industrial operation or some non-medicine operation, generally you have a CEO who can direct people and you're all part of one group and one organisation, whereas what I find often in medicine is you might be part of the nuclear medicine department or you may be part of the medical imaging department, and that makes it difficult. This is an issue for radiation safety in reaching into other departments such as surgery and vascular surgery or cardiology, where you may not be part of the reporting lines to have that input into how people should be working safely. Now, a big part of that as well is people like the visiting medical officers and the medical officers or the specialists who have multiple appointments at different hospitals. And so they can come in, they may just be there for half a day a week, they don't know what's going on, you may not know that they exist, and so that makes credentialing difficult. It makes giving people radiation badges difficult. It makes getting radiation badges back difficult. And so there is a real need for systems and processes really around credentialing VMOs. And I think the same might apply to veterinary practice. So I've definitely had issues raised about who should be a qualified therapy vet planner for a horse or a dog or a cat. Is there a qualification? Do they need to be part of the college for oncology and that sort of question? Or is this the person appropriately qualified to CT your horse? So there's a bit of a credentialing issue there that probably needs to be worked on. Obviously in Australia we have multiple jurisdictions. We have beautiful guidance from ARPANSA, but every jurisdiction does it differently. So we have probably an issue other countries don't face, where it's actually legislation may conflict with the best way to approve things. So in terms of getting authorisation to carry out imaging procedures, some states in Australia make the referrer the authorising officer. And this is despite the fact that the ARPANSA guideline says, well, that's a discussion between the radiological medical practitioner and the referrer or the requester. So that's a bit of a difficulty we face here. And that gets into the justification issue. And something I like to raise with at least the junior medical officers as they're coming in and doing the training is to challenge them to say, well, how is this going to change your care of the patient? And so they may not have a lot of say early in their career, but hopefully they take that through to think about the justification and what they'll do differently for their patient. And look, there's frequent flyers as well, and I think I've seen a few frequent flyers have large doses, many hundreds of millisievert over 6 or 7 months, but unfortunately the patient is dead in 18 months. So, that's again an issue of justification. And it's really interesting. It was quite good to hear the story from Lee and to get the other perspective about actually this means that we need to tell people and make them know that there are consequences as well of their medical exposure. So look, I have another whole page. I was going to briefly touch on a bit to do with ethics in terms of we have a good system for authorising radiation research where we expose patients for research purposes, but this does get a bit difficult ethically in that researchers may tell you that the X-ray imaging is actually part of the standard clinical treatment, but it may not be. And as a medical physicist, I don't have the capability to determine if it is part of the standard medical treatment or not. And I think the ethics committees also may not always be aware of what the benefit is in terms of justifying that exposure. So look, I'll leave that with, education is also an issue, and I'll leave that with, really that's about risk perspective, and having a story and a conversation, and hopefully we can have a conversation now. So I may ask Kimberly to come up, or maybe you want to stay down there and give a 5-minute introduction.
Okay, I hope this is on. Yes, it's on. Thank you so much. It's a delight to be here, and this was a really interesting day that over the course of the day, we've heard a lot of different perspectives of radiologic protection in medicine, and I think it's encapsulated a lot of the issues that I'd like to raise in terms of different issues that we still need to tackle, that we continue to work on. And we started the day with the interesting note that CT has continued to be at the forefront of the benefit, as well as continued concern about risk, particularly with some upcoming information about potential risk in children. And that is my passion as a pediatric radiologist by background. So I think that we will continue to need to keep a watch on that, and which populations will need special attention or special focus on radiologic protection. We also heard that there are wider indications for some of the wonderful technology we've had for a while, and that is especially true for CT. And there are also newer technologies, so we always have to keep ahead of that. And we saw some amazing technologies with some of the presenters, like with CT and with radiation therapy. So it's been a tremendous journey for all of us in the different modalities, also by our patient advocate, and was quite interesting to hear her perspective. We also know that when we see things like the new technologies, we have to remember that we need additional initial education and ongoing training. And in my experience and many of my colleagues, what we need resources for is to continue to have that credentialing, that education, and that training specific to that work group need. And I think that's where we see errors, and when we look back at errors, it's that initial training and then the ongoing training that needs to be reinforced and needs to be strong in radiologic protection. And it's not just true for medicine, but across all of the different radiologic protection, Mines, Medicine, Mars. So I think I would stop there and let others talk.
We'll ask Lee to have a chat now. So we all heard from Lee before the break, and maybe if you give us a 5-minute summary of yeah.
Yeah. I'd just like to sort of expand a point that I touched on in my presentation about information sheets on the side effects for patients. And I'll just read this to you because I've put a lot of thought into. I want to make sure I'm concise and don't ramble on. The exchange of information between the doctor and a patient is central to good decision making. The doctor should not make assumptions about the information a patient might want or need, nor the patient's level of knowledge or understanding of what is proposed. The patient needs to be informed of the potential benefits, the risks and side effects, and the likelihood of success. The patient needs to be given the opportunity to discuss their concerns and whether they would like more information before making a decision. How a doctor shares information with the patient is just as important as the information itself. As each patient is unique, information must be provided so that it can be understood, and if possible, at a time when they are best able to understand and retain the information. The patient must be given time to reflect before and after they make a decision, especially if the treatment involves significant risks. Providing written information that is accurate and up-to-date assists in decision-making. Clear, accurate information about the risks of radiation therapy treatment, presented in a way patients can understand, can help with informed decision-making. In order to have an effective discussion, the doctor must detail any adverse outcomes that may arise from treatment, even if the likelihood is small. Written information should be provided at the initial consultation so that the patient and their carers can review the details throughout and beyond their treatment. It is extremely important that the written information on side effects, both early and late onset, is provided to the patient prior to commencement of therapy. One model used overseas lists the risks and side effects in 3 categories. Less likely to occur, less likely to occur, rare but serious. The information will enable a clear understanding of what the patient may experience during their treatment and will be a reference during and post-treatment. As some side effects can appear many years after treatment has been completed, they will assist the cancer patient to know when and where they should seek assistance to manage these emerging side effects. And my other little advocacy point is that an online website that is regularly updated, detailing information regarding the various radiation therapy treatments for specific cancers and the known side effects would be an excellent reference for the cancer patient.
So I think we'll ask, thank you, Lee, that's terrific. Ask Keon Kang to talk. So Keon's from the Seoul National University. He's offer us a nuclear medicine perspective and perhaps the convergence of therapy and diagnostics as new technology that's coming on.
I'm a nuclear medicine physician. I take care of my patients with diagnostic and therapeutic as well. And I was a resident in 1996 at the time as the first pad was installed in my hospital. And it takes us around 1 hour to get imaging, and we injected just around 50 millicurie. Now we have a very cutting edge machines we have. We injected just 6 millicurie, but it takes just less than 10 minutes. But if your point of view of looking at the administration dose, not much reduced. Only the time of the acquisition is much reduced because of, and it is a hospital needs a more high throughput rather than the radiation dose. And there's no little incentive to reduce the dose to patients. The hospital wants more revenue and more patients throughput. And so it should be a little, maybe not just education and training is enough, and maybe it should link with maybe a reimbursement system or the incentive to the hospital to follow. And also, the ICRP published a diagnostic reference level in 2017. So Korean Society of Nuclear Medicine make us some aware, and we gather the information about all the hospital. Not all, actually. We try to do that. In Korea, there's just 140 clinics, institute, hospitals is operating at nuclear medicine, maybe, and some is a very small clinic, but not all the members. And so we are always aware and making aware of them, but they are not getting to this Korean Society annual meeting at all in some of the clinics. And also we cannot gather the information. Also, they are not much interested about that. And so because of not just for the education training, they are not linked with the reimbursement system. And if it is linked with the reimbursement system, maybe even small clinics may be much aware about that. And also, in the point of view and therapeutic nuclear medicine, recently, ICRP published 140 about the therapeutic nuclear medicine. It says it is mandatory that the individual dosimetry. But in real world situation, in my hospital, Seoul National University Hospital, one of the big hospitals in Korea, so we have a medical physicist in my department. Constantly, actually, he is one developing the new software and background of engineering, and he making some startup to develop new PET-CT machines. That's why we have it. But mostly, the general nuclear medicine department don't have any medical physicists at all because of it is not linked with the reimbursement. So that's another problem. And preventing and accidents is most important thing in the therapeutic nuclear medicine, but it occurs in my patient. And I take care of patients with neuroendocrine tumor for the lutetium-177 dotatate, but it is not approved in Korea yet. I have to send to Malaysia, a private hospital. I already sent 200 people. One of them died after injection of the free lutetium because, and they are now well trained, the technologists didn't know much about it. And lutetium should be boiled, I mean, actually heat it up with dotatate up to 90 degrees Celsius in the heating block. At the time, the heating block was all over, but there's no temperature monitor. Also, even TLC showed a single peak with pre-lutetium, but he didn't know that, what it means. If there's 2 peaks, and it means that 50% of the rebuild, and it should not be injected, but single peak, and he can injecting it. Actually, he injected 5 patients from the Korea. One cannot survive because white blood cell is totally going to the down 0 after 3 weeks later, and because of sepsis, one cannot survive. So preventing the accidents is most important, very seriously, but education training should be done to every corner, especially a big hospital is not so much problematic, but very small clinic, but it is very difficult to accomplish. Thank you.
Thank you. I think we'll ask Maria to have a chat to us now. I think you might talk about integration. You're from the World Health Organization, so you might talk about integration of radiation protection into healthcare, in quality healthcare.
Thank you, Cameron. I would like to make a few points that I was thinking before, and today some of them came up again. I think that if we want to really make a significant change in terms of quality and safety in healthcare, one possible strategy is really to try to integrate radiation protection into what already exists in the healthcare system and what is growing and becoming a priority today. And it is the quality of the care. This is today a priority for all the health authorities and for the health workers. Sometimes when we address them, starting with radiation protection, we don't necessarily perceive that they are so receptive or empathic. But if we put up front the answer to the question that they daily ask themselves, how can I improve the quality of the care of my patients? And we go with the solution. One more, radiation protection is not the magic solution. It's one piece of the very complex puzzle of healthcare, but it's a very important piece, because we just learned that because of that, you lost a patient. And so that is my proposal. And when I was thinking about healthcare quality, what are the dimensions of healthcare quality or quality of care? Care that is safe, that is one of the conditions. So we are in the right way here. But also effective, people-centered, and very much we learn from Lee about this, timely, efficient, equitable, affordable, appropriate, and accurate. So safe. And then I was wondering, what is safe for my colleagues? Is it the same as for us? So I asked the question to my colleagues working in patient safety, and the answer was quite simple, much more simple than my answers to them. They say safe, or patient safety, or safe care, is when patients are not exposed to any avoidable harm. And then I thought, well, maybe we go around, and if we could present radiation protection in that way, that we will never go to a level of risk zero, but we will do everything we can do, and safety culture will be one major way to achieve that, to ensure that our patients will not be exposed to that level of risk or harm that we could prevent. Probably this would work. And I know I have very limited time. I took a couple of more things. The other thing is, well, just to remind you that we have opportunities around the quality of healthcare now. The discussions in the health system are around universal health coverage, and this is not just access to services, but services that have quality. Also, the big discussion is integrated people-centered healthcare, so we can integrate their radiation protection. And another big discussion now is the rational use of medical interventions. And I think we can articulate there our principle of justification, which sometimes, again, with that terminology is not necessarily understood in the same way, but when we start talking about rational use of the interventions, we can get their empathy to work with us. But we have a challenge here, and today was raised during the panel, during the session, and is the issue that when we discuss justification, we are a little bit, maybe, we are doing something that is kind of what I call the counter thinking. Because there is a perception in the health professionals and patients also that the more we do, the better. More medicine is the best we can do. And our message in radiation protection and in healthcare is whatever is needed, when it's needed, where it's needed. Not more nor less. And sometimes this may be perceived. So that I see is a challenge when we raise awareness. How to tackle this counter-thinking, for instance, to explain that screening may be good, but not always is good, that there are some harms, overdiagnosis, incidental findings, etc. Sometimes it's a challenge. I will stop here. I have my point.
Yeah,
Thank you.
You covered a lot of points. So I would like to connect with the question of ethics. As everybody remember already, long times ago, there was the recognition that radiation protection is not only related to science. I can add that also is not only related to technology, and so it's rely on ethics. And here we can put something more useful and used in this time, that is ethical and social aspect, just introducing also communication. Another point that correlated already with this told by Maria is the question that now there is a great expectation due to the high development and increase in the medical aspect, and so a great expectation from people and the patient and also the medical organization in the result of the medical technology and also in radiation protection. You can expect it to have everything, results, and so on. And what is happened that if the expectation is not met, so there is somebody who is not agree with this, a great problem. And one point is that we have to realize that lamenting about this not expected result, also as lamenting the aspect of uncertainty that we have in radiation protection for different aspects already touched in the previous part, and so is not a solution. So the idea is to try to find a process and a model all together. So one approach is like this, in this situation, that ethical approach, so ethics can help in order to try to discuss the question and to try to go all together with the engagement, so also the centered approach for care approach and so to arrive to a sort of agreed solution that in any case would be, yes, okay, we perform this kind of procedure with radiation, or we decided not to do, but working together. I just would like to add one sentence that is related to ethics in general, that include commission, but also omission. This is more related with the question of consent and the modality of performing consent, taking consent from the patient. Because if we took both commission and omission, it seems that one is accountable, that is one of our value, not only if have problem for what has done, but also the opposite, also if one should do something and did not. So I think that this aspect, that is the nuance, opposite nuances that we have, it's very important in the question of informed consent, because the idea to give just a paper and ask the signature from the patient is not ethical from some point of view. Okay. Thank you.
Thank you. Lodewijk, please.
Good evening. I'll make it short, and I want to build on what was told earlier by Nicole Martinez on the veterinary applications. So I'd like to tell you a bit more about veterinary applications. You know by now that in veterinary today, everything we do in human medicine, you will also find in veterinary. Maybe a bit less, maybe there's a lag time, but you'll find it all. It's all being used also in veterinary. And just as in human medicine, and what Maria just said, the point where we want to arrive is to have quality care also for these animals. And that should include radiation protection considerations, both for the staff and for members of the public, and including also the animal that is exposed. And there's one enormous challenge in the world of veterinary practice, and that's a very fundamental one, and I've seen exactly the same 30, 40 years back in human medicine, and that is that many of the practitioners are convinced that what they are doing is of no harm whatsoever, nor to themselves, nor to the public, nor to the animals. So it takes some convincing, and it's, in fact, we met hundreds of people specialized in veterinary diagnostic imaging and also in radiotherapy a few months back in Basel in Switzerland at the occasion of a yearly meeting they had. And it was surprising to hear that most of them said, oh, but what I'm doing is just like diagnostic imaging, so there's no harm because animals don't live long enough to present with any harmful effect. Well, that is wrong. And it was very surprising to hear that even the leadership of these organizations was unaware of these facts. So we have a big educational effort to do from a radiation protection point of view, to tell and repeat, and we will need to repeat it often, I guess, that there might be also harmful effects on the animals and on the people surrounding the animals when procedures take place, or have taken place, like in nuclear medicine. And our starting point of our task group was that if we're doing exactly the same things in veterinary medicine as what we're doing in human medicine, then the standards of protection should be the same. We are not going for lower standards, and that's a big challenge. And one of the practical difficulties we encounter in veterinary is that this poor veterinarian working in a small private practice gets, if he uses ionizing radiation, which they almost all do, they have all kinds of roles and responsibilities. They get it all, and they have it all in their backpack. And one could wonder whether they are really capable of doing it all. So, for instance, I read an interesting Australian document, which is the code of practice for the veterinary applications, and they distinguish like 3 major roles. One is what they call the responsible person, which we normally use is licensee, so the license holder. We have the veterinary surgeon. That's the clinician that decides on what kind of thing he needs for that animal, and we would call it a referrer in more general terms. And the third kind of role and responsibility identified in this Australian document is the one of operator, and we would call it a radiological practitioner. Now, in a small practice, this one single person veterinarian will do it all, or is supposed to do it all. And in a small practice, he will take up this role as responsible person, as licensee, which means that he has to deal with facility. Yeah, and that becomes complicated because a lot of the, especially on the large animals, it becomes like off-site, so a bit more difficult, a bit more challenging. There are some issues with certain equipment. We know that because the standards applied for the veterinary equipment are not always the same, and often a bit lower than what we use for medical imaging in humans. There's also problems with, like, from a management point of view, like, they're also responsible for seeing that they can survive economically. And that might be a challenge. And Nicole already told you about this self-referral reflex that might hamper correct justification of procedures. In that role of licensee, of responsible person, the same veterinarian is supposed to draw up a so-called radiation management plan. And one of the items that he should touch upon in a lot of bigger institutions would be called for the help of a radiation protection advisor. Well, no, in this private practice, the same veterinarian is supposed to do it. And the question is, can he? And then I come back to what Cameron said in the beginning, like how to judge whether these people are competent enough to do all these things. It's a very challenging thing to do, both the roles of the licensee, of the referrer, and of the radiological practitioner. Each of them has difficulties, has big challenges. So I'll end there, if I may.
Thank you. So I think we have a few microphones to share. Excellent. I guess possibly this picks up on one point about education, and so you talk about the vets not being well aware of the risks, and I've experienced the opposite, where new surgeons, emerging areas of radiation use, increasing areas of radiation use, for example, vascular surgery, and they discover that they get DNA damage from radiation, and suddenly there's a panic about that. So, I mean, this is an educational issue within healthcare. How do we approach that? Do we go and knock on doors and impose ourselves, or how do we network and make those contacts into these emerging areas of technology and use? Anyone?
Well, actually, Dr. Van Bladel is by training a vascular surgeon, so he actually has received some doses. But you were talking about patients got doses? The surgeons, yes. So in the United States, there are now more and more pressure by accrediting agencies to have training programs, at least online, before you are credentialed by your hospital to do fluoroscopy for any kind of procedure, be you a vascular surgeon, an orthopedic surgeon, a radiologist, which you would get that training, or cardiovascular, interventional proceduralists. So I think that that's the way that we're heading. I don't know how other countries handle it.
If I may respond, because I have personal experience with what that means, and the lack of education and training might be cruel almost. When I started off doing surgery and using a C-arm every day, I had zero understanding of what was happening. In the terms of, I knew everything about the surgical procedure, I did not know anything about this C-arm I was using. I knew how to push a pedal, and that was it. I didn't know where the radiation was coming from, I didn't know where it went to, and if I couldn't see well enough on the screen, then I shouted at the technologist that was manipulating this thing, and when they asked me what should I do, I said turn some buttons, because that was all I knew. And it's only after I've started to do residencies abroad that I started to have some indication of what I was doing with this C-arm, what was happening, and how I should protect those around me, myself, and also to get a good image which I could work on for a reasonable dose. But there's absolutely a need for education and training programs in these sectors, because radiologists, they learn how to do it. Nowadays, cardiologists also, but in orthopedics, etc.
So I guess...
I think it's a key, a very important question. And what I think is, and again, I cannot avoid going to the healthcare system. Something that is today a big problem in the healthcare system is the lack of skilled health workforce. I mean, the skills are what is in the priority. And based on your question, what I think is that it's time for shifting the paradigm of what is the healthcare professionals dealing with radiation. We need to change that paradigm, because you mentioned now a list of cardiologists, vascular surgeons, etc. But based on what we see during this week and in other events, we need to talk about radiopharmacists, radiochemists, biomedical engineers, IT engineers, and also we need to break, I think, the boundaries and the silos between modalities. Because, and today we had an excellent talk showing an example in radiotherapy when we were dealing with radiotherapy, with PET-CT, with MRI, so radiology, nuclear medicine, radiotherapy, interventional radiology are not anymore silos. So to address this with education and training, but keeping in mind that these are not separate disciplines anymore. And really, and today I pick up one word from today, was something like multi-modalities and multi-professionals, this was used several times, and this is something that we are seeing in many other fora and meetings, etc. So I think if we can break that, change the paradigm and break those silos for education and training in radiation protection.
I just want to add one more thing to something I wanted to say, that ICRP publication 113 talks about minimum levels of radiologic protection education, and I think it's a very strong publication to look for.
Thank you. Very clear.
Is working? Yes, I would like to see that I want not to disconnect the question of skill, of scientific, and so with the good behavior, with the ethical part, because sometimes the professionals with a great skill for their work, as we know in the past and we don't know now, they decided not to take their dosimeters. So I think that the attention of their behavior, not only on the scientific part, and so behavior for themselves and behavior for the patient. For instance, the real involvement of the patient in the decision for this. And I think that these ethics, that we consider ethics always as something, okay, a nuance that is not in the practice day by day. But really it's not like this, because it's just with the thinking we have the idea what is correct also, and not the paternalistic approach that the medical doctor or the radiologist that know is an expert can do also for the patient without the idea if the patient agree or not agree about this, because normally say, the patient don't know, okay, is a lack of respect of the person, and so on and so on. I think that it's not possible for us to change like this today, because there is also a sort of ethics, even if it's an old ethics, of the doctor who decided to do the best for their mind, yes. But the idea to start really with including ethics in the reality of the education and training, not just the idea, we have to start with ethics today, okay, tomorrow we will see also that. In the university also it's like
Thank
this.
You. Okay, one very quick comment, please, yes. Yeah.
I just have a question, and ethics is very important, but the ethical level is very different from the person to person, and that's one of the most important issues is maybe transparency. If there's somebody else is monitoring about you, and so you're doing very ethically, but if there's nothing and monitoring for you, and so many people is done. Yeah, Paulo.
Thank you. So I think we might quickly turn to one of the questions on the iPad, which fits in with this, the question of education. So which countries have best defined competency standards for various medical uses of radiation? So for example, orthopedic surgeons, cardiologists, etc.
I can mention one publication which comes from the European Union, and that cites all types of education and training skills, competencies, so theoretical knowledge, and it doesn't say how many hours it should take, it just says these are the endpoints you should reach. So these are the things people should know, be able to, and what mindset do they need to be able to do this. And it's just as well for radiographers, as for radiologists, as for cardiologists, etc. So a number of professions are mentioned. And starting from that point, within a European working group, we have developed a similar set of education and training requirements for the veterinary sector. So this could serve as some kind of reference.
Sorry. I support that document because I think they were 19 professions. But they took this approach, the knowledge, the competence, and the skills. So in that way, I think we could cover what you said now, because in the skills, they included what is wrongly called soft science. It's not at all soft, but the humanistic components, safety culture, etc., in the skills. Because you can have, as you said, the knowledge and the competence, but not that part. So if you cover the three, it could be an approach. So
we'll take another question from the iPad. So again, we're jumping a little bit down to the, how's the best way for us to document what is standard clinical practice while also giving, the needed flexibility for patient care? Is it? Can we define? Sorry, is there a way to define standard clinical care for a particular patient or condition? Is essentially the question here on the iPad.
Well, I think that question is defined by each country or region, by their standard guidelines and protocols that are developed. Is that the question? So the question is considering, I think we have to go to the one before. No?
No, I don't know.
Considering how to...
Basically, how do we document?
How to document clinical practice in a manner that is robust while providing much needed flexibility. Absolutely. So we don't want to be too narrow and too restrictive, but absolutely. And I think we do that in how we practice with our guidelines that we have to provide. For example, right now the Joint Commission in the United States requires that each institution that does practice and does imaging on patients, we have to have protocols, but it doesn't say what those protocols are. So it's very specific, saying that we have to have protocols for everything we do that has ionizing radiation or MRI for safety purposes, and when we get inspected for accreditation, we have to be ready to provide them in writing, electronically, and explain them. And then if we have any events, we have to be ready to have a quality improvement program ready. So I think that's the way, that there's flexibility. We don't have to be all exactly the same. That said, there are minimum standards and guidelines for how we should perform those CT scans, for example. They can't be really thick slices anymore. They have to be pretty thin, as an example. So, yes.
Now I read the question. How you document, I completely agree, and how to document and come into radiation protection to the scope. Clinical audit, I think, is crucial, because that is the way, based on this existing references on what is good clinical practice, clinical audit is a key tool in supporting the implementation of radiation protection, and you can document to improve the quality. It's not regulatory at all, it's really peer review, but it's a way to document if the practice was really a good practice.
It's a little of both.
Sorry, I'm not sure that I exactly in the same. The question of reference levels, for instance, the question of reference levels, so different example for nuclear medicine in different countries. I take note of the document, those that are made to of Europe, you know. I think that for a proper approach, I think that we can discuss why for the same type of procedure we have so different level of radiopharmaceuticals and activity and those of those and so and so. Somebody told me that this is related to the different age of the apparatus and so, but also can be determined by the repeated approach that the country is used to do.
Oh, right, so there's an educational component,
This
and there's equipment component, but there's also been a lot of harmonization between Europe and North America to have similar.
There's also the two associations for different countries of medical nuclear medicines that propose different, so is approved by association, proposes so different value or radioactivity for the same exams.
So you're bringing up another good point, that at the very first, our CMO, the Australian CMO, had a very good point, and he basically said one of my mantras: standardize where we can, but be flexible when we don't have enough scientific data to make a recommendation. So that was, I think, a really good point.
Thank you. So we'll take another question from the iPad, and this is quite a good one. So, and we're jumping a little bit in topic, and the question is decision support software having a positive effect on justification and optimization in diagnostic radiology? This one.
Yeah, well, I can speak briefly to it, and I'm a big fan of decision support software, but it is only one step in use of in radiology, diagnostic radiology. It could also be applied in other systems of care, like radiation oncology. It's like a clinical guideline. But it's only one tool, and it's meant to, again, standardize where possible so that 85% of the time we have an answer, but 15% of the time our clinical order is not going to be clear, and we're going to have conversations about what imaging test to order. So that's its tool. So.
In my opinion, the clinical decision support systems have proved to be effective as tools to support justification, but not optimization. No. This is our experience. For optimization, the tools really can be, for instance, the diagnostic reference levels. But the clinical decision support tools, yeah, they have proved that they can really improve appropriateness, and this has been proved through clinical audit.
Right, and the only other thing I'd say is that in a way, if you pick the right test, you're also picking which way a CT, for example, is performed of the chest. So, for example, if you're saying that you need a CT of the chest for pulmonary embolism investigation, then you're ordering it the right way up front instead of the wrong way, which in the past we've had a lot of trouble with, and sometimes we have to repeat the study at the wrong dose because we didn't get it done the right way first. So in some ways, optimization and secondarily is affected.
Let me approach or come to an answer by starting at a different point. In the beginning, and I'm talking going back 100 years, it was very easy. Like a referrer would propose, based on the anatomy, what radiograph he needed or she needed. With a lot of modalities and a lot of procedures, it has become quite complicated for the common of referrers to do that right. And we have seen over the course of like 20 years now that if you hand out or publish simply a written document, it doesn't work. People may know that it exists, but they don't read it because it's an extra step, etc. If you have decision support, it helps a bit as long as it's decision support separate from the referring procedure, it helps only a little bit. If you can integrate it in the referral process, so the moment you ask for a medical imaging exam and then you're more or less forced to follow these rules and to see what the guidelines say, then it becomes very interesting. But for the moment, if you separate it too much out, or if it's another extra step, it's not that helpful. And studies have proven that.
So I might take the chance. Does anyone in the audience have a question who haven't gone through the iPad? So we might hand over to the audience.
Thank you very much. Ola Holmberg from the IAEA. I'm sorry I didn't download the app. I don't do apps really. I was looking at the title of the discussion, which is Raising Awareness of Radiation Protection in Medicine. And I would like to ask the panel, how do we raise awareness where it's needed? I mean, we have maybe close to 10 million radiation workers in medicine. We have the public, the patients, we have decision makers who decides on the budgets. So how do we make sure that we don't only discuss this among ourselves, but because we're already converted, I think, here. So who needs the awareness? How do we raise awareness? Do we need to raise awareness? And I would also be particularly interested to hear our patient advocates' view on this.
Yes, I think it's vitally important that it's raised, and I sort of hinted, again, I talked about having a universal website, and I think, you know, people are very nervous about radiation therapy. I can only talk from the groups of people I work with, so I'm not focusing on more on radiation therapy for cancer. But I've heard old GP doctors say, have radiation therapy, it's really can be dangerous. And that's practicing clinician that's giving really antiquated information. And I know from my working with researchers today that radiation therapy today is so more advanced than it was 20 years ago, even 10 years ago. So I think it's vital that there is really good information there that's accessible for everybody. GPs, they're the primary carer in most instances for the patient. It's the GP that you often go back to. It's the GP that I had to see once I wasn't with my specialists anymore. So they need to be armed with really strong information that's accurate. Now, I know that Ranska, who I'm on the Faculty of Radiation Oncology Council, I know that groups there have tried to work with GPs about informing them, and they go to various groups and have GP evenings, but they don't always turn up. You might get 20 when there could be 500. So there needs to be very, very good up-to-date information given, not only for the patient, but also, as we talked about, the actual safety aspects of it. Websites are really good, but how do you make people read the website? How do you turn really poor clinical practice into modern-day practice? And that's sort of a decision-making that I don't know if there's an answer for, but it is really needed. And Australia is quite educated country. I don't know what it's like in other countries, but there's still a lot of lacking of information there amongst the general populace. I knew nothing about radiation therapy before I had it. And I know so much more now, only because I've been very involved in research.
And I have a patient with neuroendocrine tumors, and the first patient I met in 2017, at the time there's very little, and it is an orphan disease, and it's in Korea, almost only 200 people. And so I'm promoting making some patient advocate for neuroendocrine tumor in Korea, and they set up the social network services, and then it's the name of the band, and so they talk each other. It is much easier to understand the patient to teach the other patient. And so they have a regular meeting, and just about twice or 3 times in a year, and I always attend there and the Q&A, and then just around 20 people are gathered together, and they propagated the information to the other patient. It's much helpful. Yeah, thank you.
Yes, I think that is important, the awareness of radiation protection in medicine, in particular in the professionals we already have, but for the youngers, in order to create a new generation for this with more attention, that is radiation protection is not something that give you some more work to do, but yes, and sometimes you skip, but this is very important, very significant for themselves, from the patient. So respect for this area, including also the question of communication with the patient, so the involvement. I know that normally when we talk about the communication for the professional or the medical doctors to the patient, the question is the time. So the question is the time, because I think that for the professional also say, I have to explain here because I am correct about what we choose, and we have waiting over the door many others, and so it's a question. Yes, also this I think is not a problem only on the professional. It has to somebody else in the administration have to take care how to communicate the question of risk to the patient, because it's not possible to say to the patient, don't worry, nothing, everything is okay, or many other things that we know normally to the patient, because this is not correct and not respect of the patient. And from the other part, the patient go home, go to internet and see, but this doctor don't know what is the risk, and so is from the other place. To take awareness and to take seriously this part of medicine that is radiation protection.
I'd like to add just one single aspect to that, and that is graded approach. If I'm making a radiograph of a finger, I'm not going to spend half an hour explaining what I'm going to do in terms of radiation risk. On the contrary, if I'm going to propose radiation therapy to a patient, then I need to talk not just to the patient, and probably several times to the patient, because as the lady here explained, usually if you come up with the diagnosis you have cancer, in the first few hours, even days, you will not be very receptive to very scientific educational information. So graded approach is crucial, and then a thing often heard, and especially in the radiology setting, is I don't have time to do that. Well, it's not just you, and if you apply the same graded approach, you will probably have time. I see that in many cases, pediatric radiologists seem to have found time to do it and find it worthwhile doing it. So why should the others not be able to do the same if you use your staff members, if you educate and train them in how to communicate about advantages and disadvantages of a procedure? And it's just certainly not limited to radiation issues. You should also discuss a lot of other problems.
I think that has to be part of the professional preparation to be also able to maintain the respect, the dignity of the patient, and so also in the communication. That normally is.
I think, Kimberly, you wanted to add something?
Well, I think you've covered it. I just wanted to thank Ola for bringing up a tough subject. I think it's not something, it's a journey. It's a marathon. And IEA has done a lot of work on reaching out across different regions, just as WHO has. And I'll add that a couple of things we brought up is patient advocate groups, and I've worked with them at hospitals to bring them into radiology. Another group that we haven't touched on a lot is penetrating into something that's become very popular in the United States called patient safety organizations, or PSOs, which is now almost a requirement that we report errors to these groups, and these groups review and weigh in on what is happening in hospitals so that we can help be more transparent and improve how we do things. And then another idea is to work with different disease-specific patient advocacy organizations like Susan Komen Foundation. You had a little ribbon up on your slide, Lee. But other organizations that use imaging heavily. And they've been very helpful to respond to and help us improve what we do.
Yeah, sure.
Short. To answer the very good question from Ola, I would answer yes to your question. I think you said, do we need to raise my answer is yes. And if I could, maybe to all the stakeholders, but if I could select two groups, I would say, the patients, the families, and the communities, and there are already some networks, and we have here one example in Australia, and for you, if you don't know, in the world there is a network called Patients for Patient Safety. Are patients, advocates, or families that work for patient safety, and there are already more than 300 or 350 champions in the world. But they are champions because they have been trained. So you have to raise awareness and in a way to do focused education and training for them. And the second group is the medical and dental students. I think it's a long process. You invest now and you get the results maybe in 10 years, but it's really something that we should address. And there are also organizations. The World Federation of Medical Students have associations in all the countries, and you can engage them. In fact, we invited them to the workshop we organized jointly with ICRP. They are very keen to work, so that is another group of stakeholders that are very important.
Sorry. Very short, it's a bit provocative or a question mark regarding radiation therapy. The question is, in radiation protection, in my mind, yes, is included also the question of how to prevent accidental exposure in radiotherapy, because this is a lot of the debate on this, because some part of the community say, yes, this is safety, this is not radiation protection and so on. But we remember that we have the document 112, yes, preventing accidental exposure and so. And this is a question of culture, because yes, it takes some time. We make a survey in Italy, we a lot of work on this, and it is feasible, and you can reduce the possibility of.
Thank you. We might ask Lee to make a final comment.
I just expand on what others have mentioned, that in Australia we have a group called the Australian Cancer Consumer Network, which is coordinated by the group I'm with, Cancer Voices, and it has all the subgroups of tumour streams, and I think they're really good outreach groups on their website. So they would have, for instance, BCNA would have breast cancer issues, and because breast cancer and prostate cancer is a high radiation therapy and diagnostic testing, they're the groups that would have really good access to really good websites, and I would urge incorporating those sorts of consumer groups.
Thank you, everyone. I mean, and a couple of the questions on the iPad have talked about how to communicate to patients, do we talk about stochastic risk, and raising questions like that, and also asking how you talk to senior clinicians in a hierarchical environment like a hospital. So I think that's certainly the panel's given us quite a few good ideas. I thought we might want to talk about emerging trends and some of the new technology. So the question here is, what does the panel see as an emerging technology or increasing trend in the use of technology that will significantly be a radiation protection focus in the future? I'm sorry. And I think, so what is an emerging technology or trend that will require significant radiation protection focus in the future? And I think one example is the crossing of boundaries between nuclear medicine and radiology, for example.
I can cite just one tendency we see strongly in the veterinary sector, but it's not that different from what we see in humans, and that is the booming business of CT, CBCT, and everything like it. So let's say a plain film radiology and plain film radiography is almost seen like inferior medicine. You need to do better if you want to have a certain status within the profession, or doing what most people think is good medicine. If you provide quality medicine, they expect you to do a CT scanner every 5 days. And that's a problem. And these people are pushing practitioners to do unjustified exams. There's a tendency for people to ask for the best care possible, and they think that having a lot of diagnostic testing and preferably the very sophisticated testing, then you're good.
In nuclear medicine areas, recently the total body PET is developed by the Simon Cherry and UC Davis, and finally the machine is coming out from the United Imaging in China, and it increase the sensitivity 40 times means that you can inject just 0.25 millicurie of the FDG and get imaging, the same quality. And so reducing the dose. But I think that cannot be happen because so many hospital buying $10 million the machine for not just for reducing the radiation dose, but maybe increasing the throughput. Maybe it can be expanded to the cancer screening because it is only the less than 1 millicurie. Means that less than 1 millisievert you can get exams, and so it can be maybe a proliferative imaging and in the community basis, not just in the hospital-based one, maybe.
Yeah, so I'm going to jump on that and say, the bad news is there's, I think, not enough education on justification. I think it's weak, and ICRP can help with that. On the other hand, the good news is we're getting sub-millisievert CT, and we can thank a lot of research into that and new technology. So, there's the good and the bad, and I can see in the future whole body imaging to be like, your annual checkup. Not that I want that, I certainly do not. I don't want overdiagnosis and false positives. But I do see no end in the use of imaging in medicine and in veterinary and in industrial uses. And AI with it.
As technology or trend, in the use, I agree that the screening now is it is a good thing, but it can be a big issue. People want to know and cannot tolerate uncertainty, neither doctors nor patients, and we all want to know if we have something, and that is a big challenge. But technologically, no, I don't see the big challenge because we can do, as you said, very low dose CT. There is not the problem. The problem is on the use when it is not justified. Technologically, I still see that the problem on fluoroscopy-guided interventions has not been solved. We see still issues in radiation protection in that area, protection of workers, and still we see deterministic effects in patients. So I still think we should do much more on safety culture in that area. And as emerging, what I have been seeing in the last couple of months, I agree with you that is, I think, in the area of radiopharmaceuticals with therapeutic purposes, theranostic, and when you are mixing beta emitters, gamma emitters, you have to deal with waste management, breastfeeding, a new of nephrotoxicity, a lot of things that we are not facing in radiotherapy anymore because these things were fixed in a way. That is a first perception, but you may have a different opinion. It could be good to know.
Are there any other questions from the audience? Please.
Reinhard Lohse, I'd like to come back to the point of justification. Maybe it's because of more and more lawyers are around in the area of an hospital, but we know a term which is called defensive medicine. Defensive medicine means we performing X-ray procedures and also laboratory tests and other things, not for benefit of the patient, but to protect ourselves from doing errors. For example, Kimberly knows it from pediatric radiology, all these skull examinations, if they have a blind, simple trauma, they're absolutely necessary and are only done for self-protection. And this number of examinations is increasing, and it needs a lot of clinical experience to avoid these examinations. After 30 years of radiology, my experience is simpler to perform an exam than to cancel it, because if you want to cancel it, you have a long discussion with surgeons and all the other ones. And that's one of the risks we go into performing unjustified examinations just because they are ordered to be secure, I'm doing the right. And another experience for me is the younger the physician in the emergency ward, the higher is the workload of the radiologist.
Direct correlation.
No other, well, that's, very obvious, I guess. Yeah.
Maybe just add, it's not only defensive medicine to defend people against litigation, I think. There's another thing that plays also, and that has to do with proving the things you're pretending. Show me, have the proof that when I was a young surgeon, I could easily say, I feel, I smell, I hear, and then based on these personal observations, I could go for one or other intervention. Nowadays, that would be unacceptable. That would be considered substandard care, because I would need to prove first, and preferably with imaging exams in my hands or something, and with laboratory tests, that it is as I thought it was.
I guess I'm going to switch back to another thought that, since I'm still thinking about Ola's comment, how do we raise awareness? And I think another way, we're all, believers, another way we do that is by pooling what we know and creating more larger databases. I mean, we have the internet, we're all connected, and I'm a big believer that we need to share data and we don't want to charge for it. So where possible, I think we need to create more registries. I know some people are doing this. I think we're not doing it enough. So I'm a big proponent of thinking about ways to share more data, such as our radiation therapy patient data that's not, breaching any confidentiality, but the dosimetry data, so that we can learn about tissue effects, normal tissue effects that affect many people, and we can learn more than just, relying on old data, but there's a lot of good data that we could help our patients as well as our researchers, so we can do better in radiologic protection. And I think that's particularly important for children, but for everybody, because we have many survivors, and I'd like to see us look more in that direction.
What about the Blue Button initiative in the US? And the patient can be downloaded all the data by herself, and it means that you can easily compare with the other different hospital-based one, and some is more, some is
available.
less. So,
yeah. Well, I'm also a big believer that everything that is done to a human being, that it's theirs as a patient, is theirs. They own it. They should own it. So that's another change in terms of authority gradient. We ought to make it very flat instead of vertical. And I think I've heard several talks today where I think we're all moving in that direction internationally.
Sorry, you talk about the tissue effects. What about the lens of the eye?
Well, that too. Yeah.
Open a question.
Yes.
In the practice now, if effectively is implemented or not.
Well, in children's hospitals, CT,
next meeting.
We're very conscious of that in children, and less so in adult practices.
What we see when we visit countries where technologies are emerging, and this is why I raised the point of fluoroscopy-guided interventions, you see good equipment, new technology, but lack of culture in the workers. So the lens of the eye, they have the glasses, they don't use them. So this is why I don't see the same problem, so serious problem, in diagnostic imaging, in the CT departments, etc. What we see, the culture of using the lead aprons, etc., still exists. But in the lab cuts, where workers, and not just the radiologists or the surgeons, but the nurses, they are there, and sometimes they have no clue. So, and of course, again, the patients, because we still continue, and we know that we see this skin lesions, burns in patients. And these procedures are being done more and more now in children for cardiology anomalies, malformations. So I think it's both, the workers and the patients.
Yeah. But the question of the length of the ice is not completely on the professional, is on the regulator, on the legislation, and so, because if you don't have the legislation in the country, it's difficult that the single can react on this.
Yes. I think certainly,
Just one idea that pops into my mind is having good science is one thing. Conveying that good science is another. And I think we're all, as a community, failing a bit in communicating, and especially in communicating with patients. Telling in simple terms what is really going on and what the risks are, what the benefits are, is not an easy exercise. And that is, I think, what we should do if we want to raise awareness, and that goes for patients, but also for practitioners and for referrers. Our job is to communicate better.
So I may take another question from the iPad. So, we may have some good resources here. So I guess, is the use of CT, if the use of CT is being driven by medical practitioners who are green and not confident, how can we design standards of protocol that prevent this while educating the clinicians at the same time on better investigative methods?
Well, to a great extent, we have, like what we call appropriateness criteria in the States, and what we call in the European settings, we will call it differently, like referral guidelines. And at the IAEA level, they have called it clinical imaging guidelines. But it's all the same. It's like offering like a sort of assistance, guidance to people that would like to refer to a medical imaging exam, and seeing to it that they get the best exam possible, and a justified one, an appropriate one. So these things exist. They don't exist yet in the veterinary sector, but I know that societies are working on.
But in fairness, early in your training, you're going to overtest. We know that. This is a known thing. You're going to order more blood tests. You're going to order more imaging, and that's normal. That's expected to a degree. We just need to keep an awareness that we could provide some radiologic protection guidance on justification. So.
Are there any other questions from the audience? I possibly wanted to raise an issue with optimization. So we have the DRLs in Australia. They seem to be working well. We've seen talks and presentations on the reduction in DRLs in our experience. Although sometimes when I talk to radiographers, I'm not sure they understand how to use DRLs. And also in fluoroscopy, I'm not sure there's an understanding of the continuous improvement process where they should be reviewing their doses weekly or monthly and considering the cases. The DRLs seem to be working, but are we confident that the people who should be applying them see them as something more than a limit and a tool that they can use?
If they consider it a limit, which it is not,
yes,
then there's not too much harm done. What we see often is because of the terminology used, diagnostic reference level, that people think that they should aim for that dose. So, yes, we need to educate people about it. And one of the practical problems we see quite a lot, and not just in my country, but also in surrounding countries, is that they do the measurements to provide a DRL, locally, regionally, nationally. But then you're supposed to use these data to do an optimization exercise, continuous improvement, and that's what's failing. So everyone's measuring, nobody's doing something about the higher doses.
I think, look, we have about 6 minutes left in the session. I wonder if any panel members have any last comments, or if there's any quick questions from the audience. Okay. So I think we've had a fairly good discussion. Hopefully, we've covered a lot of issues, and really education seems to be the big issue, and also a patient focus is very important. We've heard that, and I think I'd like to thank the panelists and thank everyone for joining us and staying for the session, and close the session.